This video will cover adult hypertension management, including diagnosis, risk stratification, and optimized treatment pathways. Defining thresholds for hypertension involves comparing clinic versus home blood pressure readings. Home thresholds are generally 5/5 of a millimeter of mercury lower than clinic thresholds. Treatment actions vary from rechecking in 5 years for normal to lifestyle advice or immediate consideration for severe hypertension. Accurate blood pressure measurement requires optimal patient positioning and protocol. Ensure the patient is silent, back supported, with the arms supported at heart level, legs uncrossed, and feet flat. Use the lying and standing rule for diabetics and the elderly to check for orthostatic hypotension. Risk stratification means treating the patient, not just the number. Step 1 identifies automatically high-risk patients like those with CKD or type 1 diabetes. Step 2 uses QRISK3 for those aged 40 to 84. Essential baseline investigations are also shown. Personalized treatment targets vary. Standard clinic target is less than 140/90ths. For the elderly, the target is less than 150/90ths. For CKD and diabetics, targets are lower. For frail elderly, focus on tolerability and safety first. Lifestyle is the first line of defense. Interventions like weight loss, the DASH diet, and increased physical activity can significantly lower blood pressure. Smoking cessation is the largest single factor in reducing overall CVD risk. Initiating monotherapy is guided by age and ethnicity. Patients under 55 or those with type 2 diabetes start with an ACE inhibitor or ARB. Excluding Black Afro-Caribbean ethnicity, patients 55 and older or of Black African/Caribbean origin start with a calcium channel blocker. Treatment escalation involves dual and triple therapy. Step 2 is dual therapy, combining an ACE inhibitor or ARB with a calcium channel blocker. Step 3 is triple therapy, adding indapamide. Always check adherence before escalating treatment. Step 4 addresses resistant hypertension, which is uncontrolled on the triple therapy regimen. Check potassium levels. If low, add spironolactone. If high, add an alpha or beta blocker. Refer for specialist advice if still uncontrolled. Safety first, kidneys and sick days. Pause ACE inhibitors, ARBs, diuretics, metformin, and NSAIDs during acute illness to prevent acute kidney injury. The monitoring loop shows required checks when starting an ACEI or diuretic. For hypertension and pregnancy, ACE inhibitors, ARBs, and thiazide-like diuretics are teratogenic and must be stopped. Safe options include labetalol, nifedipine, and methyldopa. The target blood pressure is less than 135/85 of a millimeter of mercury. Protecting the kidneys in diabetes and CKD, the blood pressure target depends on the albumin to creatinine ratio. If ACR is high, a tighter target of less than 130/80 of a millimeter of mercury is needed. A CEI or ARB is mandatory first line for diabetics with proteinuria. Never combine ACE and ARB. Critical emergencies requiring same-day action include malignant hypertension and acute symptoms. Routine specialist referrals are needed for young onset, suspected secondary causes, resistant hypertension, and pregnancy. In summary, follow these 5 golden rules. Measure right, stratify risk, apply stepwise logic, mind the gap for targets, and ensure safety by pausing certain medications during, quote, sick days to prevent acute kidney injury.